Okay.
Okay, boleh start.
Assalamualaikum and good morning everyone. I'm Emilia. Today I'll be presenting topic today of rapid sequence intubation. Is rapid the keyword, and I am supervised by Dr. Suraya Farid. So this is our objective for today. We are here to understand definition of RSI, able to list and understand 7 Ds in RSI, and also review RSI pharmacokinetic agent, and also the role of delayed sequence intubation that I will explain more with it. So, how do we define RSI? RSI is an administration of a potent induction agent after pre-oxygenation, followed immediately by a rapid-acting neuromuscular blocking agent to induce unconsciousness and mental paralysis of tracheal intubation. Where RSI in ED, patients are assumed not fasted, so there is risk of aspiration, and the use of weight-based doses induction agent and paralytic agent instead of titrating to effect to achieve immediate unconsciousness and paralysis. Meaning we in ED we give bolus doses instead of titrated dose like what NS do in OT. Okay. Indications. So we go to the indication of intubation. Why we intubate patient? What patient do we intubate? So when there is failure of oxygenation, for example, in cases of acute pulmonary edema, severe pneumonia, failure of ventilation in patient with status asthmaticus, for airway protection in patient with a lot of secretion, bleeding or unconscious, and in patient where we anticipate the clinical deterioration.
Contohnya apa yang anticipate clinical deterioration?
Transportation from one side atau jarak itu.
Contohnya patient macam you kalau you kat district kan hantar patient positif contohnya kan DCS macam 12 macam okay, so you never know along the way apa boleh jadi. So it's an you boleh intubate patient, so you can use RSI lah. Okay, lagi satu. Contohnya patient in severe sepsis, septic shock, with severe acidosis kan, you can anticipate dia akan further deteriorate. So before patient betul-betul dah deteriorate, and it's going to be difficult for you to intubate masa tu, then you intubate early. Okay, alright.
So siapa kalau burn kan dia anticipate dia.
Yes, betul. Itu lagi satu. Kalau patient ada inhalation injury, then you dia dah tapi still bercakap lagi, tapi bila you examine ada nampak soot dekat dia punya throat, with time dia akan getting more swollen and dia akan occlude your airway dah. Okay, so you anticipate early lah when you intubate.
So this is the contraindication for RSI. The absolute contraindication are patient with cardiac arrest, and also if the operator is inexperienced. So in patient in arrest, usually we do crash intubation instead of RSI. And relative contraindication is when we anticipate technical difficulties when laryngoscope or intubation.
So what does it mean by relative contraindication ni? Maksudnya memang tak boleh nak buat tu macam mana?
Find a different way to make things difficult.
So not really, this is relative. You can do, tapi you have to be extra cautious lah. You can understand by, or you have to anticipate what is your complication later. So bukannya tak boleh buat RSI ni, tak boleh, but you kena careful lah. So it's relative.
So I mentioned before the crash airway, where we which means oral intubation without drugs, where if we do it in cardiac arrest situation only, and patient is completely unconscious, pulseless, and unresponsive and also apneic, tak bernafas. So the advantages of RSI, it facilitates and expedite intubation, increase success rate, decrease time to intubate, minimize trauma, minimize hypoxia and hypocapnia, minimize risk of aspiration, and also minimize hemodynamic effect of intubation. Well, I'll explain further what is that. So the complication of RSI, it can fail. It can also cause tracheal and esophageal injury, hypotension, hypoxia, aspiration, and also cardiac arrest. So we go to our second main point today. 7P of RSI, which comprises of the first one, preparation, pre-oxygenation, and the new I just know I also just knew about this. There is no more pre-treatment. It is changed to pre-intubation optimization, paralysis with induction, protection and positioning, placement with probe, and also lastly post-intubation management. So the first one is preparation. What do we need to prepare?
Before we start, when you talk about 7P, it's not just a sequence. Okay, for each P, each one of the P's two, you have to know what is the aim of each P two. So kenapa apa yang nak capai when you're doing tu kan? So achieve or not before you proceed the next step. Okay, so every time you nak buat RSI ni, you have to remember you nak capai apa. Not just okay, first P dah, second P dah, third P dah. So next. It's not, it doesn't work like that. Okay, so nanti Dr. Emily akan explain lah one by one what is the aim for each P tu. Okay.
So the first one is preparation. So what do we prepare? The equipment. So how do we remember? There are mnemonics with the mnemonics that can help us to list out all the equipment lah, which are meals. So the first one, monitor. Monitor, which include monitor, mask, education, and also including sedation post intubation. So nak intubate tu order lah. Pasang cardiac monitor, ambil back valve mask, order medication, and then ETT lah, our tube nak size apa, and kena prepare lah, letak gel, letak stylet, airway exam. Benda ni dah mention lah last week. What are the airway exam? Covered last week. And then L, laryngoscope, and also lubricant. S, suction, stylet, shrink, and also stethoscope. Then we prepare the patient. How do we position the patient? There are a few positions. The first one is sniffing position, where we align the oral, pharyngeal, and also laryngeal airway exists for better glottic view. Instead of this, kita manipulate and then jadi macam ni lah, the better glottic view ni. Second one is RAM position lah. RAM position which we usually prepare in patient yang obese with short neck, where kita letak towel kat sini, so the tragus is same level with the sternum, where it optimize upper airway, patency, and laryngoscope view. It facilitate also mask ventilation, and following intubation, it improve mechanics of ventilation. So,
sorry.
sorry.
Yang position yang ni you dah buat during preparation ke? Faham? Betul. Mesti nak patient rampant ke ataupun mesti patient dah rampant ataupun dah sniffing position ke during your preparation? Memang contoh patient APO, you nak intubate patient APO kan, ataupun severe COPD, severe asthma patient yang datang tripod semua. So you all pakai mask, nak preparation, okay. Patient, cik baring, I nak buat sniffing position during. What you present during your preparation?
Kita selalu position lepas kita bagi betul-betul sebelum kita nak intubate lah. Sebab kita pre-oxygenate dulu, baru kita intubate.
Pre-oxygenate?
Kita pre-oxygen, bagi oksigen
so
dulu.
yang ni bukan, it's after the induction dan paralytic baru
baru
nampak positioning. Yang so position patient should be macam mana sebelum intubate yang during your preparation? Patient will know himself kan APO, they know how to COPD, they know how to want to open the airway, maintaining the airway. Tapi sebenarnya we will prop up lah, kita tak during nak force dia baring APO ke apakah lagi baring dia lagi patient lagi cepat reset semua. Okay, so what the most patient comfortable. No, usually patient will maintain. APO dia akan maintain, akan buka airway. He know what the most comfortable position for him. No? Jangan force patient baring. No? During you prepare sebelum nak bagi induction agent dengan cryolitic semua. No?
So, assessment of difficult airway, what do we need to anticipate our patient lah. Bila kita tengok, kita tahu, oh ni masih susah. And if we tak confident, we have to call for help lah. For panggil senior ataupun EP. So, difficult BVM, there are few assessment lah kita boleh buat. The first one is how do we anticipate back valve punya difficulty, pakai Mons, difficult laryngoscope, lemon, difficult placement of extrarobotic device, rods, and cricothyrotomy difficult in cricothyrotomy is short. So these are the mnemonics ambil from. So Mons ni selalunya it consists of masil, susah nak masil bila ada obstruction ataupun patient obese, age 55, tak ada gigi, stiff lung or C-spine. Kalau susah nak road study apa? Road study placement of extrarobotic device. Sebenarnya patient yang ada restrictive mouth opening, ada obstruction ke, distorted, and also same stiff lung juga. Lemon ni kalau intubate, nak intubate kita tengok loop, evaluate, melapati lah tip of mouth opening tu, obstruction, also patient yang obese, also neck dia.
So kalau you tengok one by one, step pada awal tu kan, you assess is there any possible difficulty masa you nak bagi BBM. So you remember lah, the one is Mons, you must Mons, must seal. Patient ada janggut banyak sangat, design, patient yang elderly, cengkung, patient yang ada, contohnya ada no teeth. Kan obstruction of obesity tu selalunya bila you nak back susah nak ventilate, so maybe have to short neck kan patient ni kan. Lepas tu age tu elderly lah, usually ada cengkung, no teeth, because patient yang ada ni denture. So how, adakah you akan remove the denture untuk BBM?
Go in, open your eye, go in.
So the jawapannya no, you don't have to remove masa BBM, masa you bagging. The dentures actually help untuk you place your mask. So make sure dia tak longgar lah. Pada longgar kamu you have to remove. Kalau dia remain in place, cantik, this back. The denture tu akan tolong for adequate seal. Bila you nak intubate, baru you remove. Okay. Yeah, so for rods, okay, you remember lah, the LMA tu rod kan, is a rod, shape kan. So, restricted mouth opening, you cannot insert, because your SGA tu ada bulat kat depan kan. My LMA, obstruction, ada obstruction pun you can, obstruction dekat tongue, convex, disrupted or distorted anatomy of the mouth. Or the stiff lung tu, after you dah masuk, you nak back, then it's going to be difficult to ventilate. Intubation, this biasa dengar kot, lemon. Kan? Look externally, and sama juga yang macam kata janggut lah apalah. Evaluate T32, ni malam pati punya scoring. In ED, kita tak guna sangat malam pati ni. It's useful, it's helpful kalau kita boleh buat. Tapi tengah takip ni, orang sudah buka mulut lah, nak ukur ni. Maybe kalau saya pandai Rafli kan agak, it can help, but kalau tak buat, it's not compulsory punya step lah. Obstruction, obesity, sampai obstruction, patient obese, short neck, then neck lah, neck. Restricted neck mobility, short neck. Then you also have to anticipate. Kalau you fail your intubation, fail to ventilate, maybe surgical airway is an option. So siap-siap tengok ada restart from the short punya anatomy tu. So usually semua ni dia akan cause distortion of your anatomy for your surgical airway.
So this I what explain by Dr. Zuraya dapat score yang saya nak buat lah sebenarnya kalau dekat ED setting. So we goes to the tadi tu anatomical difficult airway. This is how do we anticipate physiological difficult airway. So we call it as hot killers, which consists of hypotension, oxygenation, patient with hypoxia, and also PH, patient with metabolic acidosis. So what do? We have to optimize this patient before we intubate. So for hypotension, we give fluid or start inotropes. Oxygenation, give adequate pre-oxygenation or admit oxygenation with hypoglycemic candida. For patient with metabolic acidosis, during apnea from RSI tu, meaning lepas kita bagi paralytic agent tu, supported ventilation may be necessary waktu sebelum nak intubate tu. So usually patient yang ada metabolic acidosis ni, we can also pre-oxygenate with ventilator. Saya jumpa.
So apa significant hot killers ni? Kenapa ada hot killers? Apa yang dia kill? Kenapa? What is important? Ini preparation part You identify. You identify. You might not need to include yet, but you identify. So kenapa hot killers ni important? RSI investigation.
Anticipate. Arrest during patient.
Hot killers ni dia, kalau patient yang ada one of the criteria of hot killers ni, masa you nak intubate tu, patient can arrest. So there's a risk of peri-intubation arrest. So you have to optimize your patient before you nak proceed lah with your RSI ni. Macam ada these three condition ni memang risk high risk of death. Start to be.
So these are the populars. And then after we gather all the equipment and also the preparation of the patient, we gather our team, the intubator, the assistant, which one yang jaga airway, jaga bubat, and all the stuff. And then we go to pre-oxygenation. Pre-oxygenation is an establishment of oxygen reservoir within the lungs and body tissue to permit several minutes of apnea without desaturation during intubation. So, what are the methods of pre-oxygenation? So, if patient has adequate respiratory drive, at least we give 3 minutes of tidal ventilation or normal breathing, or 8 breaths with full inspiration, expiration to achieve vital capacity in less than 60 seconds, which require patient cooperation. If inadequate respiratory drive, macam patient tak bernafas dengan cukup, atau patient tak bernafas pun, we give PPV, back valve mask, at least 15 liter per minute.
Oh, yang nombor satu tu ni with using what? Tak
boleh.
Itu apa?
We can have
High flow mask oxygen. Your high flow mask oxygen tu, it should be a non-rebreather mask. Kena tengok dia punya your mask tu, tengoklah. So ada setengah, sekarang ni hopefully tak lah, ada setengah tempat kan. Dia recycle tau. Dia punya high flow mask ni. So you kena make sure the function, how a non-rebreather mask works. Okay, dia ada valve dia semua tu. And then untuk pre-oxygenation ni, you just naikkan je. The maximizekan the oxygen. Beyond 15 liter per minute pun boleh. You naikkan je oxygen sampai 20 bunyi. Masa nak intubate tu kan. Naikkan je. Provided patient ni lah. Breathing by himself. Can obey command. Okay. So you can give at least 3 minutes of tidal ventilation. Patient breathing sendiri. But you have to at least 3 minutes lah. Okay, you breathing by yourself, SpO2, maintain 100. Okay. Ataupun 8 breaths with full inspiration. Macam mana tu? Maksudnya apa? Deep breath. So patient ambil deep breath 8 kali. Deep breath and exhale this. So 8 kali. To mention ni lah, SpO2 pun maintain 100. Kalau patient yang inadequate respiratory drive, you might need to use NIV. Tapi NIV, you boleh guna NIV. Tapi sometimes cannot tolerate NIV. What you can do is you help with your BBM. Okay, ideally kena ada ni lah, big valve, but setengah tempat tak ada. So you assist. You kena calmkan patient, you explain what you are going to do. When you back with patient's punya breathing. Don't back against patient punya respiration. Kalau tak, your pre-oxygenation is not going to work lah.
So the adjuncts to maximize oxygenation, we can also use on top of the high flow, we also pasang nasal cannula 15 liter for continuous passive oxygenation during apnea. Patient's position and maintain airway potency. Kalau patient meaning, kalau patient kalau tak ada gap reflex, mungkin dia letak OPA.
So nasal cannula ini dipanggil apneic oxygenation, yang nasal cannula 15 liter per minute tu. Ni on top of your pre-oxygenation tu, whatever oxygenation yang di tengah letak tu kan, M ke, NIV ke, you put nasal prong, naikkan ke 15 liter. Tapi jangan letak humidifier tu. Kena connect directly. Tu dia oxygen without the humidifier. Naikkan 15 liter. How it can help is actually dia provide oxygen reservoir dekat yang nasopharynx area. So masa tu exhale dia ada kat situ lah. Because your external punya oxygenation tu it might mix with air. So you won't really get 100% oxygen. So it can help. One more thing, what is the bilakah apneic period masa your intubation process tu? At which point your patient tak dapat breathing, tak dapat ventilation during intubation. So masa tu that's breathing time after you bagi your relaxant, masa you nak intubate tu, that is the apneic period. So dia ada continuous passive oxygenation masa apnea time tu. So it's helpful lah untuk semua patient, untuk you letak dia nasal cannula 15 minutes. Maintain patient position, maintain patient airway potency lah, your head chin lift position, your thrust ke masa nak intubate tu.
So this is the graph of time to dissolution for various partial circumstances. So as you can see here, the shortest apneic time where patient dia tak akan diset kalau dia tak nafas. The shortest time is patient adult patient lah yang obese.
Tu letak guna pointer.
Obese patient dia akan diset about 4 minutes. Lepas tu the next one is normal child. Dia ada 4 minit lebih sikit. And then moderate adult with 70 kilo adult usually 6.5. And then the last one yang akan last moderately ill lah yang ni. The last one that will last longest is the normal 70 kilo adult. Dia give us time about 10 minutes. Tapi the good thing is bukan tak good. The time to recovery from the paralysis tu Scolin ni dia orang tak lebih lah. So Scolin ni will give paralysis tu more than the time of reset ni. So dia akan reset, maksudnya kita still boleh back bath lah. Beyond that, 10% time untuk recover from Scolin ni dia start at 7 minutes and then and beyond. So this one dia tak fall beyond the ni lah, still akan paralyzed. Still patient will still be paralyzed bila dia reset. So boleh still back bath masa.
So this graph actually nak tunjuk pada yang paling kanan tu kan, in a normal adult yang sihat, guna-guna yang sihat, kalau you dah pre-oxygenate kan, dia dah ada 100% oksigen, then dia apnea, dia tak bernafas. So dia ada 6 minit sebelum dia start turun, betul tak? Dia akan start reset after 6 minutes. Means dia ada 6 minutes of oxygen reservoir before dia start to reset. Dia compact dengan patient kat ED, semua ill kan. Dia nak intubate pun patient yang ill. So patient yang moderately ill, normal weight, dia start at 4 minutes tu. After apnea, 4 minutes dia dah boleh reset. Okay. Yang normal child and also obese patient is faster lah. At 2 minutes and obese tu lagi lah 1 minute je. Dia akan start reset. So, have to remember. Memang you have to remember lah for this physiological changes in critical patient with regards to oxygen and apnea.
So the next step is pre-intubation.
Yang pre-oxygenation tadi. So it's very important lah. You all do the proper pre-oxygenation before intubation. So adakah semua pre-oxygen have to use back bath mask? Kena back ke? Kena back. Semua patient kena back. Betul eh? Sebab nampak tu yang tengah daging. Is it semua patient kena bag? Mesti patient dah high flow mask initial. Okay. Then you tukar ke baggy kena bag ke? Anak? In what condition you nak bag?
Pasien yang unable to breathe.
Unable to breathe adequately. Macam contoh hypoventilation. So when dia tak breathing, so you kena assist dia back. Macam Dr. sudah cakap tadi, so back ikut the nafas lah. Kalau nafas tak cukup, then you have to back juga lah. But you have to bagi the adequate respiratory rate semua tu. Okay. So actually, so depend on your tengok condition macam mana. Okay, contoh patient yang adequate respiratory drive, okay, dia okay, death dia pun okay. So kalau dia bukan lung problem, you intubate untuk patient yang head injury, untuk airway protection, dia tak ada lung problem, even oxygenation boleh maintain high flow mask 100%. So just maintain yang 100%, tak ada masalah. You just prepare background mask untuk during intubation, you nak sambung your ETT, nak back, itu saja. You kena prepare. Tapi you tak perlu change ke backwash mask semua tu. Kalau tak ada lung problem, can maintain dengan non-rebreathing mask with yang ada waktu. Okay. Contoh, okay, yang ni yang untuk patient yang tak ada lung problem, senang. Okay. Contoh, you nak intubate yang patient yang ARDS ke very bad, even dengan your high flow mask pun SpO2 80 tak cukup kan. Nanti hypoxia, one of your hope killer. Okay, untuk pergi intubation cardiac arrest, so you kena step up. So how to step up? Maybe your high flow mask tak cukup, you can change to your next step, your NIV. You boleh P-ox dengan NIV. Contoh patient on NIV, inilah dengan NIV, tak perlu tukar ke high flow mask semua tu. Okay, just continue your NIV dengan proper positioning. Okay, your NIV. Okay. Dan boleh add on your nasal prong macam yang doktor sudah cakap tadi, your nasal prong. Kalau yang perda patient, maybe you boleh up to 5 liter, okay. Tapi once you dah bagi priority dengan patient dah tak bernafas semua, so you boleh upkan your nasal cleaner to up to 15 liter. Ataupun you pusingkan senang. Sometimes our manometry dia just 15, kan, 15 sampai 15 liter saja. Tapi you boleh pusingkan, habiskan semua flush. The flow rate is more important juga. Okay.
So, in pre-intubation optimization, it identifies and mitigate area of cardiopulmonary vulnerability that may complicate resuscitative effort, even though kita intubate tu senang. So we have touched a bit earlier about this. It also mitigate adverse physiologic reaction to intubation. So what are the adverse physiologic reaction? So laryngoscope and manipulation of airway, it can activate coughing and gagging. Infant, it can cause bradycardia. Adult, it can cause high BP, bronchospasm, increased ICP, and also heart rate. But in highly emergent cases, it is not worth to wait for treatment and can be omitted. So the drugs we give can vary according to the condition. So these are the list of what we can optimize prior to intubation. So usually we give fentanyl, because fentanyl can blind a sympathetic response. That we mentioned lah, increase ICP, high BP tu, it's important. Kenapa kita tak nak patient kita ada high BP, especially in patient with aortic dissection, ICD, and cardiac ischemia. Fluid and blood, we can give in patient with hypotension from bleeding and dehydration. Pressor, ataupun kita panggil push dose of adrenaline. In patient with hypotension, refractory fluid challenge. So the dose we give usually 0.5 to 2 cc every 2 to 5 minutes. So BiPAP and CPAP, pre-oxygenate lah. Hypoxia refractory to face mask. Kalau tak cukup, then we change to BiPAP or CPAP. And also insert chest tube in patient with kita identify ada suspected tension pneumothorax. Pasang dulu baru intubate.
Pressures tu?
So in fentanyl, how do we prepare? Usually we give 1 to 3 microgram per kilo. On set dia less than 60 seconds. Sangat cepat lah. So duration dose dependent, but it can last 30 minutes for every 1 to 2 microgram per kilo. But the adverse effect, it can cause muscular rigidity in high induction dose and also bradycardia. So the push dose that I mentioned, how to prepare.
And so fentanyl semua bagi fentanyl. Your open activation. Yang dulu pre-treatment kan, no, otherwise now kita ada omit lah yang first step to pre-treatment which yang dulu LOAD kan, Linocaine, Opioid, A itu atropine untuk pediatric. D itu kita bagi 10% of your devasculating agent which semua pun tak ada evidence lah, kita pun tak practical. So pre-treatment not by remove from the third P. So this means to pre-intubation optimization which more important lah, which kita target all your optimize your patient before intubation, your ocular semua tu. So for the P-MET tu yang more important, yang more evident important adalah your fentanyl. So tujuan kita bagi opioid ni adalah untuk mainly adalah blunt your sympathetic response. Okay, so hanya condition yang high BP ni we need to blunt sebab when you insert your laryngoscope dia akan smooth all your sympathetic response semua. Okay, sometimes dia akan shoot high BP sekejap semua tu. So anything high BP will cause harm to the patient. This is the condition that we need to consider fentanyl. Okay, contoh patient BP high, GCS low, so we know most likely dia takut hypertensive emergency, patient ada ICB. Okay, patient yang severe chest pain, BP high, kita suspect high LD dissection. This condition that we need to give fentanyl. Okay, untuk dos fentanyl yang untuk blunt the sympathetic response, actually bukan yang kita selalu bagi 50 mic, 100 mic, yang tu more toward analgesia effect. Okay, yang blunt sympathetic tu sebenarnya dia higher dose lah, 2 mic per kilo, 3 mic per kilo, up to 5. Tapi kita taklah bagi high macam tu sebab dia ada risk of side effect dia. Kita takut rigid wall syndrome. Satu effect yang kita sangat takut, rigid wall syndrome, which kalau patient nanti you intubate, you nak ventilate pun dah rigid lah, cannot ventilate langsung. Yang tu yang side effect kita takut. That's why kita taklah bagi very high dose dan fast bolus terus in high dose. Kalau ada rigid wall syndrome tu, even you bagi reversal naloxone pun dia tak akan reverse. Yang ni yang menakutkan.
It's rigid.
Rigid.
So you tak boleh chest suspension itu memang tak boleh lah. So I careful with fentanyl.
So untuk patient yang contoh hypotension, you intubate yang patient septic shock ke apa ke, yang tu we want BP higher. Post intubation pun we want BP higher. So at that condition kita tak nak blunt the sympathetic response. So mostly kita tak bagilah at that condition. No, kita tak nak blunt the sympathetic response.
So how do we prepare? Everything push dose. So the first step is we take 1 cc from ampule adrenaline tu, mix dalam 9 cc saline. So we got a 10 cc. So from that 10 cc, we draw another 1 cc and then add on another 9 cc. Mean 2 step lah of campur dalam 9 cc saline tu. Then we get 10 cc yang consists of 1 cc bersamaan 10 microgram of adrenaline. Okay.
So dia jadi 1 in 100,000.
1 in 100.
1 in
Mic. 100 mic.
100,000.
It's 1 cc. Bersamaan what?
Pure berapa? Pure is 1 in
1,000.
1,000. Okay, when you dilute once, 100. Okay, so the
Another
what sekali?
100.
1 in 100,000.
So untuk ada dos nak bagi berapa? Yang ni pun dos adrenaline
Kita bagi
0.5 to 2 mil. Ya, all dilute sendiri lah, jangan panggil MA ke apa ke, takut dilute salah. No? Dilute 2 kali. Our NMC ada ephedrine, boleh guna juga. Ephedrine. Okay. Okay lah. Tak apa lah. Adrenaline.
So the next step is paralysis with induction. So in paralysis with induction, it is given as rapid and we push immediately before paralyzing agent. It facilitates unconsciousness, one arm brain circulation time. It minimizes time from LOC to intubation, and it should provide a rapid onset and a rapid recovery. Satu brain, satu turun terus. Just simply sebab cepat. Provide rapid onset and a rapid recovery from anesthesia with minimal CVS and systemic side effect. So these are the list of drug that we can use and the dosage.
First ayat tu
Okay, boleh tu.
give as rapid IV push immediately before.
Cepat. One after another cepat. Okay, these are the dose, the agents and the doses. So the
Betul ke dose tu? I think of fentanyl 5 to 15 mic. 15
mana?
tu fentanyl.
Mic.
Oh, mic per kilo.
Mic 0.5 to 1.5.
Okay, one.
Oh, injection something.
We omit this one.
Induction we only got 4 yang di.
Itulah 4 jam. Induction agent commonly used ada 4 jam. Middle.
Yang tu bukan.
Okay.
Dose pun macam
We use,
pelik.
okay.
Macam
Intermediate and propofol. So the first agent is midazolam. So the dose is 0.1 to 0.3 milligram per kilo IV kali total body weight. The onset is 60 to 90 seconds and it can last around 15 to 30 minutes. The adverse effect are apnea, hypertension, and also variable response. So this is the drug. So dia clear color lah. Hypertension and apnea lah, it can cause. And then second one is ketamine. Ketamine we give 1.5 to 2 milligram per kilo. The onset is same, 60 to 90 seconds. It can last around 10 to 20 minutes. It can use in any RSI, especially in hemodynamic stable or if patient with reactive airway disease, which can cause bronchodilation. So kenapa dia it can relatively use in all patients, but dia tak cause hypertension. But the adverse effects are increased secretion. It should be used cautiously lah in cardiovascular disease where it can cause in patient with hypertension or tachycardia. It can also cause laryngospasm, but it's rare, and also increase intraocular pressure.
Tadi yang you sebut
There's intraocular and also intracranial lah.
tadi you sebut yang dia tak cause hypotension. Not really true. Yang new study, yang airway study, actually all your induction agent will cause hypotension juga. Cuma especially untuk patient yang dah critically ill, yang sympathetic response ataupun breathless, this the patient yang can cause hypotension juga. Bukannya semua patient yang semua patient they won't cause hypotension, akan ada juga. Cuma ketamine the mechanism actually dia attack banyak for a bit complicated. Dia bukan yang lain semua adalah you potentiate your GABA which cause CNS depression terus, tapi yang ni dia ada kita panggil NMDA receptor and antagonist yang main dia. Cuma yang dia memang akan stimulate your sympathetic response sebab as you all nampak yang kita bagi PSA semua tu patient dia akan jadi slight tachycardia, jadi BP high side from your baseline. Dia akan stimulate your sympathetic increase your catecholamine release. So dia good untuk patient yang BP low, untuk patient yang septic, yang shock semua tu. Even you intubate untuk patient yang trauma, patient yang low BP. So ketamine is a better choice as compared to your mida, your propofol yang lain. Dan juga reactive airway disease untuk patient yang serious COPD, asthma, ketamine. Sebab dia ada bronchodilator effect.
So the next agent is intermediate. Intermediate punya dose 0.3 mg per kilo. Onset lagi cepat lah, 10 to 15 seconds. It is suitable for most situation including hemodynamically unstable patient other than sepsis or seizure. But the drawbacks are adrenal suppression and also monoclonus. So you can see the color of intermediate is white compared to other agent.
Tak semestinya hari itu kita ada yang clean.
Oh.
So dia macam sekarang itu dia macam propofol lah, macam susu color. Clean juga. So dia is one of the most hemodynamic stable. Dia tak increase much your kacau much your apa dia your BP, your heart rate. So it's one of the most hemodynamic stable. Okay. Tapi cuma ada some controversial pasal sebab dia boleh suppress your adrenal suppression. So untuk patient yang macam septic shock semua tu, we need the cortisol semua tu. Tapi dia yang ni yang controversial, so sometimes kita tak bagi sebab dia boleh suppress your adrenal for 1 to 3 days sometimes. So sometimes kita akan bagi hypocort kalau you bagi patient yang septic shock.
What is the material untuk patient mana? Nak intubate patient mana?
Patient yang hypertension.
Hypotension.
You tu?
Not caused by sepsis.
Tapi kita boleh bagi untuk hypertension. So intermediate tu kenapa? Dia apa stability? Dia ada satu lagi keywords. Apa stability?
10S stability.
And
And
again stability. So you need intermediate ni untuk patient yang ada cardiogenic shock. Okay. So kalau macam sometimes cardiogenic shock, okay, kita aminkan dia boleh dapat lagi vasospasm, coronary vasospasm lagi, causing MI apa semua kan. So intermediate ni one of the the best induction agent for cardiogenic shock, and it's not the best for the sepsis, hypovolemic, so other kinds of shock bukan. I mean, not really diharamkan, tapi it's not ideal for other kind of shock. It's ideal for cardiogenic shock.
A good choice untuk yang severe head injury. Yang head injury,
Yes, head injury.
sebab dia show that dia maintain your cerebral perfusion pressure.
So the last agent is propofol. The dose is 1.5 to 2.5 milligram per kilo. The onset also passes 15 to 45 and it can last around 5 to 10 minutes. Very short. So it is used in hemodynamically stable patient with reactive disease and also status epilepticus. But the adverse effect are hypotension, myocardial depression, reduced cerebral perfusion, pain on injection. And it's very short acting, and we don't actually use propofol routinely in ED.
Tak use ini
Apa ada sen?
Tak, saya jarang.
Okay, so dia hemodynamically stable, reactive.
Hypotension.
So apa dia punya the good orang kata the good effects dia? Now you kata use in hemodynamically stable patient, in reactive airway disease, dan sebagainya, apa yang dia punya effect dia?
Kalau patient yang
Drawback is side effect, so apa dia punya?
The use ada apa contoh reactive airway disease.
So apa the effect to the reactive airway disease?
vasodilat macam intermediate.
Status asthmaticus boleh guna ni, tapi you guna with vitamin ketofol. You boleh buat vitamin infusion. This one induction
Induction.
Induction. So you boleh guna ketofol untuk induction. Pernah buat? Vitamin plus propofol. So dia macam jadi ketofol.
So paralysis and also neuromuscular blocking agent. The ideal paralytic agent is it should has rapid onset of action to minimize risk of respiration and hypoxia, rapid recovery to facilitate a return of ventilation if intubation fail, and it has minimal hemodynamic and systemic effect. It produces paralysis, do not provide sedation or anesthesia, and use immediately after induction agent. and it can be divided into two type of group. Which are depolarizing and non-depolarizing agent. So the depolarizing agent is succinylcholine, or we usually call it choline. It binds to acetylcholine receptor, which produces fasciculation and paralysis. Wherein the depolarizing agent is glucuronium. Glucuronium, also pancuronium. It competitively inhibit the postsynaptic acetylcholine receptor and produce paralysis.
Yang you kata minimal hemodynamic and systemic effect tu macam mana? Sebab kalau patient yang critically ill, paralysis dia takes a huge difference juga.
Macam Dr. Fiza dah pernah tanya last week lah. What the effect of choline ni yang produce fasciculation ni. Bila it produce muscle fasciculation, it increase oxygen demand, consumption. So bila dia increase oxygen consumption tu, dia akan
Dia apa? Dia tak nak tolong.
tapi foto kat situ je.
Agak-agak lah. Ni untuk critically ill. So critically ill kita we are not patient yang critically ill. So kita tak galakkan patient guna paralysis. Siapa yang pernah intubate sekali dengan patient yang motor skin tu? Tak ada. Yang motor yang gila-gila semua tu. Kita tak guna. Kita sebenarnya induction dia. Kita tak guna paralysis. So dia akan increase in patient tu dah lah hypoxia, hypotension, metabolic tissue acidosis, tissue hypoxia. So bila you bagi scoring, okay, so dia akan increase tissue oxygen demand. Okay, so dia akan tarik, dia lagi increase dia punya demand untuk oksigen. Dah lah patient tu kurang oksigen, kurang perfusion. So dia lagi increase demand, benda that was vicious cycle. So dia akan worsen dia punya metabolic acidosis. That's why lepas you bagi paralysis tu, okay, kalau patient yang critically ill dapat assist. So bagi I, first attempt intubation, lepas tu assistol is not successful intubation. Okay, ada satu patient you do angina, patient okay je dekat ini. Lepas tu lepas je intubate dekat NS intubate, lepas je intubate CPR assistol. Maksud dia is not a good punya sebab patient tu okay, not on anything. So basically first attempt, successful first attempt is not equivalent to successful intubation. Okay, so you kena resuscitation sequence intubation. Ini resuscitation ada yang tadi kan, tak pasal resuscitation sequence intubation. So resusc dulu, so you optimize, so 10 seconds intubation, and then patient need paralysis ke tak?
So we go further on depolarizing agent, choline. The dose is 1.5 milligram per kilo. It is mostly preferred agent due to the rapid onset and offset. So the onset is 45 to 60 seconds and only lasts around 6 to 10 minutes. And it has absolute contraindication where we don't give patient in insignificant hyperkalemia, malignant hyperthermia, patient rhabdomyolysis, and also stroke or burn more than 72 hours old due to upregulation
about intubation, kan? Tu yang is oxygen consumption.
The side effect is trismus, fasciculation, and also bradycardia, especially in children. So the next agent is non-depolarizing. It is used when choline is contraindicated or prolonged blockade is warranted. The agent of choice are rocuronium, glucuronium. So yang kita selalu ada kat sini roco lah. The dose is 1 milligram per kilo. It has short onset, but it can last up to 45 minutes. Glucuronium kita ada tu.
Mestilah ada. Apa pekoronium?
Biko.
Beko tak ada.
Pekor
Onset about 90 seconds. So a predicted difficult airway is the most common.
Korea tak cakap pasal asal Korea.
Yang jarang guna juga.
Jarang guna. Oh, this one untuk
Sebab ada rock.
Tapi usually kalau lepas intubation tu, you boleh guna atrial untuk patient yang ARDS yang kita nak fully paralyze dia punya respiration.
So because non-depolarizing agent ni last long, it has dia ada reversal lah of the agent. So the agent of choice is neostigmine and also sugammadex. So the action of yang ni, how neostigmine dia reverse, dia adalah acetylcholinesterase inhibitor yang which allow acetylcholine to continue stimulate the NMJ junction, NMJ and cause muscular stimulation. Sugammadex, dia encapsulate and bind molecule for oroporonium or bicoronium, then dia akan hilangkanlah the effect. So the next step is protection and positioning. So in protection and positioning ni, dia ada few technique lah yang controversial and I will tell which one yang recommended lah. There are Salix maneuver, burp, and also ELM, external laryngeal manipulation. So the first one is Salix maneuver. It is application of pressure on the cricoid cartilage to compress the esophagus. It is said to prevent regurgitation and aspiration, but actually not supported by evidence in prevention of aspiration, and it also may interfere with intubation and ventilation.
Sebab apa?
Sebab apa?
Tak. Dia betul ke dia compress esophagus?
Tak support
Ha?
tak supported by evidence. So actually tak
So tak buat kan?
tak buat dalam.
Sebab apa? Sebab esophagus tu bukan kat bawah. Sebab tu anatomy kena tahu. Esophagus sebenarnya kat mana? Sebelah. Kalau dia buat ultrasound sebelah kiri. Tu bukannya belakang airway, di sebelah. So kalau dia tekan, so dia akan displace, esophagus still open juga. So unless kalau you nak tekan esophagus bronchi ni.
Ini yang orang panggil cricoid pressure tu. So kita tak beda lah cricoid pressure tu.
Menyusahkan your intubate juga.
The second technique is burp, backward, upward, to the right pressure. You see, it is to improve glottic view, where the assistant maneuvers, dia yang assistant yang buat lah, apply cari the cartilage and pushes macam tadi lah. Tapi tak buat.
You buat ke tak? Tak buat.
Tak buat. So the last technique is external laryngeal manipulation, where the intubator buat sendiri lah dia to improve to improve glottic view. The left hand pegang laryngoscope, the right hand mobilize sendiri dia taruh cartilage lah until dia nampak the vocal cord. And then bila dia dah dapat tu, ask the assistant to ganti lah. So ELM actually was found to improve percentage of glottic opening compared to the previous technique lah, Salix maneuver and burp.
Ini bukan intubator yang buat. Yang assistant dia akan put taruh cartilage dulu. So you tengah intubate kan, yang intubator. So you akan adjust the hand of your assistant. Where is your best position you nampak. Okay, maintain that pressure. So you pegang tangan dia. So sebab you yang pegang, you maintain, nanti you suruh dia. Pressure you dengan dia tak sama, lain. Dan lari juga. So dia akan put dulu, you pegang tangan dia, adjust dan maintain that pressure. Okay, this position. So you intubate.
Gambar yang bawah.
Tu satu single, satu tu. So kalau seorang-seorang boleh buat juga lah.
Betul lah.
Orang tak pandai lepas tu kena dirisaukan. Tidak pasti. So macam mana pun yang boleh buat.
So lastly is placement with proof. After paralysis has been achieved, finally we can intubate
Eh,
them.
not fair. Ada yang last. Ada satu lagi.
Apa lah? Yang mana?
Atas mana? Asal is a direct evidence of placement of proof. Placement. Ada.
Satu.
It's a direct evidence. Maksudnya you tengah, kawan you tengah intubate, you tak rasa kat sini. Okay, so direct visualization dia nampak in real time dia masuk ke tak. So kalau tak masuk, real time tak masuk, terus kita buat tak payah nak tunggu analysis CO2 semua. Yang ada CO2 is not accurate. Sebab kan dia kata the most accurate ni. No, not accurate. So apa? Okay, kalau let's say ada CO2 tu, kalau ATT dalam stomach, ada CO2 tak dalam stomach?
Ada, tapi kan kita tengok dan ada graf. Ada bilang.
Dah buang.
Okay, so this is
Sebab kita pun
Ni ha.
okay, so sometimes kalau patient tu dia apa nama SEO banyak dalam apa nama intubator dia pun boleh dapat mimpi macam tu. So kalau dia baca study dia ada macam tu. Dia ada study exactly macam tu. Macam trachea intubation. So it's not the most accurate. The most accurate is the direct visualization. Confirm direct visualization. Okay. So lepas tu you letak ultrasound. Ultrasound is a real time punya evidence.
So this is the direct visualization of what you are supposed to see before you intubate, and do not attempt to pass your activity if you haven't seen this view. So the classification following endoscopic view from Maclehan, just how to classify it 1, 2, 3, 4 based on what we see. And then last step is post-intubation care, which include buat ECG, check SpO2, capnograph. Kita tengok tadi lah how kita nak check ETCO2 tu. And then insert rescue, buat chest x-ray, ambil EKG, and also set the sedation lah, post-intubation. So
important post intubation sedation semua tu yang betul, because your induction agent dengan parental agent tu short acting saja kan, tak lama. So kalau tengok patient start breathing, patient menangis, because they are actually awake sebenarnya, not fully awake lah kan, tapi dia sedar. Sakit tau, apa ATP dekat throat tu kan. So always remember, bila during your preparation step tu dah siap-siap medication tu, include your sedation.
So this is what you have seen lah, bila kita buat chest x-ray tu placement tu, dia tak akan membantu lah masuk esophagus ke masuk trachea ke, tapi it can help us to see at which level the ATT is. So they ventilate both lung, or yang penting sebab takut terdalam sangat ataupun terkeluar sangat. So the best level should be at the T3 to T4. Okay.
to CM from your carina. Tengok
CM
the
from
cabang above the carina.
This one I just want to share lah about one case, because esophageal intubation. So actually, from this case, what they conclude is tapi dalam case ni, what they conclude is it is O2. They argue that the best way to confirm actually from their ni lah, it is O2. Kata no trace, no place.
No trace?
No place. So what happened is this young woman, dia ASRF. Lepas tu from the HD center tu dia feed, and then datang ED and intubate. And sadly it happened during COVID lah, very 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 busy. So bila dia orang buat retrospective investigation tu, katanya staff time tu ada yang menyuarakan oh tak masuk, tapi nobody dah do anything. And then they argue that PCO2 monitoring tu tak buat. So from the discussion tu, they say that so dah jadi wajib untuk PCO2 tu dimonitor lah post intubation to ensure correct placement of ATP. So this is what has been said lah. No trace, wrong place.
Okay, so for your centers untuk tempat-tempat yang ada PCO2, you gunalah. Guna. So you nak apa, it is useful, but not all place ada PCO2. Kalau macam Teresa kata tadi, ultrasound kan, siapa bolehlah belajar. Okay, learn how to do, sebab ultrasound is operator dependent juga. Then you have to know about other methods juga lah untuk for you to confirm your placement. One of the important thing macam yang tadi tu, if you don't see the vocal part, jangan nak blindly attempt masuk. Okay, so now kita ada kita ada kelebihan, ada VL kan, so we can use that as a guide. Okay, so jangan blind je untuk masuk. Then after that you have to assess back. Apa lagi cara-cara untuk make sure placement? What establishment? Is it reliable water level? Ke dalam punya, kalau masuk esophagus tak ada water level. Dalam esophagus tak ada air. Ada kan? So your water vapor tu is not accurate at all. Okay, jangan guna water vapor as an indicator for your placement. Chest rise. Then kena careful juga. Sometimes obese patient, bila you back, your chest will rise together with the abdomen. Apa you tak tahu. Okay, so there are ada banyak cara. So you incorporate all. Okay.
So this is a case of, you see a 50-year-old male, bad pneumonia, BP borderline, very tachypneic, and he is delirious. SpO2 only 70%. So you try to nak escalate to high flow, patient tak nak. So what are you going to do? Are you going to do straight RSI for this patient? No. Cannot go through RSI. So this is where we expect to do a delayed sequence intubation. So RSI versus delayed sequence intubation. So standard RSI tadi, as I mentioned, is a simultaneous administration of sedative and paralytic agent with no ventilation until we intubate. So we can break this sequence to allow adequate pre-oxygenation without risking gastric distension or aspiration. So delayed sequence intubation is we give a specific sedative agent which do not blunt spontaneous ventilation or airway reflexes, with a period of pre-oxygenation before we give a paralytic agent. So this is based on Bingard study in 2014. So he samples 64 patients with patients which do not require emergency intubation that do not tolerate pre-oxygenation with traditional methods and were not predicted to have a difficult airway. So he performed this patient, DSI was performed using ketamine and resulted in significantly improved oxygen saturation prior to intubation. So dia kata two patient with asthma improved sufficiently to avoid intubation altogether, meaning by ketamine patient okay dan tak boleh intubate pun. So kenapa?
What does ketamine do?
Bronchodilated.
So in a way it helps with solution lah.
So this is the sequence of DSI. As you can see, dia lebih kepada pre-oxygenation tu lah before we give induction, that there are additional step. So what we do first,
Sampaikan yang what DSI do. Okay, so basically untuk yang contoh few case that you can consider delay sequence. Okay, actually is dia satu procedure untuk macam PSA. Kita PSA untuk pre-oxygenation. Sebab untuk patient yang especially dia restless, agitated, which you all nak pasang your high flow mask, nak pasang your NRV semua pun dia cabut ke sebab dia hypoxia, dia dah jadi restless ke, agitated ke, dia akan cabut semua. So you can do your proper pre-oxygenation properly. So you bagi ketamin, bagi dia relax. At the same time mungkin ada bronchodilator effect. You bagi ketamin, bagi dia relax sikit, tak agitated. So you can do a proper pre-oxygenation. Okay, mungkin tadi SpO2 tak bagus. Now patient relax sikit, dia taklah agitated, can inhale more. Okay, so you can improve your oxygenation. So you akan di-assess balik. Kalau dia dah improve oxygenation, dia assess okay, dia boleh follow your command. This a patient that maybe can improve. You can avoid intubation, which from the study ada few patient yang initial plan nak intubate, tapi after improve pre-oxygenation, patient become better, compliant to your nebulizer, compliant to all your treatment. You may tak perlu intubation. So satu lagi, kalau you reassess, you dah bagi ketamin, okay, dia dah proper pre-oxygenation, yang ni still condition tak bagus. So yang tu yang you can consider your continue your I step lah, yang bawah tu bagi your induction tanpa paralytic untuk intubation. So basically it's just a procedure untuk your pre-oxygenation ni bagi ketamin. You tujuan bagi ketamin as compared to you bagi yang nida semua, sebab ketamin dia preserve your airway effect dan dia tak kacau mas your respiratory drive. So patient still, even dia disassociated, tapi dia still protect their airway, dia still respiratory drive, dia tak respiratory depression. Itu yang hebatnya ketamin. That's why in DSI they choose use ketamin. Okay, dose dia di kebanyakan guideline tulis 1 mg per kg. So I think agak tinggi lah. Maybe you can try 0.5 dulu dan bagi, kalau still boleh up to 0.5 lagi, up to
1 mg tu macam induction lah.
macam almost near induction lah. Induction yang 2 mg for ketamin. So boleh try lower. Actually dia macam you buat PSA. Macam you buat PSA untuk pre-oxygenation. Okay, boleh faham? So only few lah, macam patient COPD dan asma yang agitated semua tu, bukan semua, bukan head injury boleh nak buat yang lain. Dah. Apa dia lah case?
So we go to the first case example lah. A 67-year-old male diagnosed as acute extensive MI clinic 3. He was started a helmet CPR. However, patient was unable to tolerate and unable to maintain saturation, and we decide for intubation. BP normal 130/80, pulse rate 100, SpO2 90% of helmet CPAP, and patient is tachypneic. So how would you plan the intubation process? Can I have a volunteer? You mean? How do you intubate this patient? Patient tak,
Kenapa patient restless lah?
tak. Tak.
Severe APO lah, is it?
Severe APO lah. Tak. Dia pun tak. They just that hypoxic lah. Patient hypoxic and decide for intubation.
Unable to tolerate, maksud dia dia restless lah.
Selalunya dia akan restless lah.
Sebab dia akan macam
Dia punya situation. Kalau macam patient okey je, patient okey, dia follow CPAP tu semua, you follow CPAP pun still tak improve. Then start improving. So unable to tolerate is another thing.
Tak.
Okay,
Can follow, tapi patient tak pick up.
can follow lah.
So dia follow command, dia okey dengan CPAP. So dia tak ada resistance nak buang CPAP.
Macam mana Dimin? So
we start from beginning. What is your RSI steps? So how would you pre-oxygenate this patient?
90% and then it's effect. The choice of oxygen. BBM.
Jangan lambat.
So sebab pre-oxygenation harap CPAP pun 90%. So kalau patient ni ada good respiratory effort, kita boleh pakai kita boleh pakai high flow ataupun
Kenapa you downgrade from
Yeah.
CPAP ke high
pakai CPAP, kita dah pakai CPAP dalam helmet kan. So tukar ke CPAP, yang tu. Lepas tu kalau patient boleh let patient breathe lah. Tak perlu begging.
Apa dia? You nak tukar ke
Pakai
TBN?
CPAP, pakai CPAP. Tapi
Pakai
tak
CPAP.
perlu bag. Tapi tak perlu begging kalau patient boleh breathe. Allow patient to ventilate lah.
Yang ni dah helmet. Dah
Helmet.
helmet. So you nak
Dah.
pasang macam mana kan?
Helmet.
Yang ni helmet kan?
Helmet. Tapi dia tak boleh wake up. So
So you maintain je. So patient already on on an IV kan, on CPAP. So you maintainkan saja your with patient dia patient punya ni, you optimize everything lah. Other things so you prepare properly. So you prepare your preparation tu you already anticipate the patient dia dah ada one of the
Okay.
sedangkan apa lagi yang boleh buat, apa lagi yang boleh buat untuk oxygenation ni.
lagi boleh buat.
Saya beri je tak.
Okay. So apa kita ada option tadi? Kita ada risk from dia ada risk of intubation arrest because of hypoxia ni kan. So you get your options tadi tu. So make sure your options properly. Lepas tu your apa nama nasal cannula ventilator tu, make sure ada oxygenation tu. Prepare juga. Okay. Then call for help. Remember to call for help. Okay, for this patient. So what kind of medication nak pakai? Preparation barang-barang tu macam biasa lah. Your meals tu. What kind of medication in this case?
So dia BP okay. We can use fentanyl for
Okay, you nak blindness,
dan sebagai response kita pakai fentanyl.
jadi muatan kardik. Okay, your induction agent.
Induction agent,
Agent nak pakai apa? Intermediate, okay. Paralytic,
boleh
you rasa normal?
normal.
Spolin, okay. Kalau you nak pilih rocuronium for this patient, you have to be careful lah sebab you dah expect dia dah ada hypoxia. So even though you nak pakai immediate external, okay, you never know once you masuk your ETT, you takkan tahu what's inside there. With hypoxia macam ini, so your apa nama paralytic of choice, preferably pakai yang shorter acting boleh lah. Okay. So ini basically MBA, GCS6, patient, ada gargling sound. So what is your next step? Suction, maybe. Normal GCS6. GCS6.
Breathing, still breathing.
Breathing.
Still breathing.
Gargling sound. Is that? Okay, so trauma, make sure your cervical kena secure. Lepas tu you gargling sound tu suction. Preparation, basically go step by step. Okay, preparation of barang-barang yang medication of choice. What you can use. Nak bagi fentanyl? Intermediate boleh.
Intermediate.
Because dia cerebral protection juga kan. You can use intermediate. The paralytic.
Breathing.
Susah kot.
Silent boleh. Okay, so intubation process semua biasa lah. Make sure kalau trauma special case you have to do manual inline. Okay, tu secure contact dia punya cycle.
Last one. Obese, septicus, dah aborted tapi tak regain consciousness. And unable to maintain his airway. So decided for intubation.
So ni this one is basically on the preparation and pre-oxygenation punya part lah. So morbidly obese, what is your preparation? What is your anticipation? So in this kind of situation, memang you tahu patient ni nak kena intubate dah ni. Because tak boleh maintain airway. So apa yang buat? Okay, you nak intubate. But while doing your intubation, while doing all the preparation, so what you can do to the patient? Wait 1 month, okay? Airway, see, your airway maintenance, what is this patient? Airway dia. Okay, walaupun you tahu intubate, what happens is, you akan biar je dengan hypnomas patient tu. Macam penting lah kan, dia hypnomas, lepas semua orang berlari-lari untuk mencari barang, intubate, ada ubat dan sebagainya. So make sure one person always stay with the patient untuk dia lah, apa nama, stabilizekan dia, maintainkan dia punya air redundancy while dia prepare for the intubation. Okay, what medication yang you nak pakai? BP pulse rate tak tulis pula. BP pulse rate stable lah. What medication you can use for this patient? BP normal lah, heart rate 80.
Tidak, vitamin.
Bagi bidang, kita boleh bagi perempuan pun boleh.
Ya,
Habis dah?
habis. So this is the confession.
RSI stands for
Rapid civil activation.
Although it is preferred technique, tapi you have to remember the rapid tu bukan je lah kelang kabut nak cepat-cepat.
Okay, so intubation. Okay, so kita ada dua. Kita ada RSI dengan PCSI. Okay, so it's a different thing. Okay, and kita tak guna rapid intubation. Kita guna resuscitation. Okay, ada dua. Okay, satu resuscitation sequence intubation, satu delay sequence intubation. Okay, so kita guna ni in the different setting. Okay, so first of all, kita nak tahu kita nak intubate, kita ada aim dulu. Kita nak intubate patient ni sebab apa? Sebab kita nak protect airway ke tak? So kalau kita nak intubate patient tu sebab kita nak protect dia punya airway, kita punya goal memang aim kita memang kita nak intubate lah. Nak tak nak memang kita nak intubate. Okay, so kita punya goal memang successful intubation. Okay, itu untuk protect airway. Okay, kita ada. And kalau contohnya patient MBA ke patient yang itulah, dia tak boleh sakit dia punya airway, dia tak boleh nak protect lah dia punya airway. Okay, and then satu lagi, apa punya the reason kita nak intubate patient. Satu airway, kita nak intubate memang patient sebab dia tak boleh nak protect airway. Satu lagi, the reason kita nak intubate patient sebab anticipate deterioration. Okay, alright. So basically, senang je. You nak intubate patient based on ABC. Okay, airway. So dia tak boleh nak protect airway. Memang wajib kita intubate lah. Okay, so kalau bukan wajib lah. I mean, kalau patient tu stroke kan, kita boleh protect airway pun tak ada lain kita intubate kan. Okay, so airway protection. Okay, B, ventilation kan. So dia ada hypoxia. So basically patient tu hypoxia, it can be due to ventilation ataupun perfusion, visual mismatch lah. Okay, so you nak intubate sebab hypoxia. Okay, it's either ventilation ataupun perfusion mismatch. Okay, C, you intubate sebab not all short you intubate. Impending cardiorespiratory arrest. Okay, impending cardiorespiratory arrest sebab tu patient tu dia critically ill, Okay, patient to severe metabolic acidosis, okay, patient hypotension and severe metabolic acidosis. Okay, so you nak potong yang hot killers tu. Okay, hypotension, apa lagi hot killers? Hypoxia, acidosis dengan oxygenation, okay lah itu hypoxia dengan hypotension dengan acidosis lah. Okay, pH kan. Okay, that one itu hot killer. So kita nak anticipate yang tu. Okay, patient ada hot killers, okay, patient ada high risk of cardiorespiratory arrest. Okay, so ABC. So then of kita nak intubate. Okay, so delay sequence intubation. Okay, bila kita nak buat delay sequence intubation, maksud dia, you rasa patient ni boleh lagi ni, boleh lagi. Maksud dia, patient tu dia ada ventilation punya, possible dia ada VQ mismatch tapi yang easily reversible. Contohnya asma easily reversible. Okay, boleh reverse dalam masa at least 24 hours. Okay, so they want delay sequence intubation. Lagi APO secondary tu APO dia ada buat okay, dia APO satu overload lah. Cardiac cause. Okay, lagi
Neurogen.
access renal failure. Okay, access renal failure, fluid overload dia, you rasa bukan resolve dalam masa 24 jam tak? Tak. Okay. So apa yang you rasa boleh resolve dalam masa 24 jam? Cardiac. Okay, possible. Lagi apa lagi? Hypertensive emergency lah kan. So that one hypertensive emergency yang easily reversible. Okay, lagi apa? Okay, itu sahaja yang you nak buat delay sequence intubation. Okay, so kalau patient tu pneumonia, so kalau patient tu pneumonia, okay, so dia dah ada consolidation kat situ. Macam mana you nak buat? Okay, apa dia akan improve but takes time. Kita antibiotik tu semua. So kalau patient tu datang dengan severe pneumonia, you type 1 severe type 1 respiratory failure, patient hypoxic, itu semua memang in the end punya goal kita nak memang kena intubate. Nak tak nak kena intubate lah. Okay, tapi that one is resuscitation. Okay, so untuk delay sequence intubation, okay, kita gunakan untuk patient asma. Okay, untuk patient yang APO. Okay, APO yang untuk yang boleh reversible dalam masa 24 jam lah. Basically ventilation punya problem. Okay, that one is the delay. So delay maksud dia you tak terus intubate. So maksud dia you bagi time kat dia. Contohnya patient tu okay, so dia APO, hypertensive emergency kan. So benda tu kalau you treat with hypertensive emergency, you bagi oksigen, you buangkan dia punya fluid, patient okay je. Okay, alright. So macam mana patient dia restless? Kalau dia kan patient APO memang hypoxic kau ni dengan tu patient restless. Okay, so basically kita nak in our mind kita nak intubate patient ni, tapi kita buy time. Okay, so kita buy time, patient ni boleh ke tak bertahan. Kalau tak boleh tahan, okay lah, intubate lah. So that was the delay sequence intubation. So contohnya patient tu hypertensive emergency, dia datang dengan severe hypertension between 200 over 100 something. Okay, full burn DPO sampai atas. Okay, oxygenation room air 60%. Patient sakit ni. Okay, you bagi CPAP, patient cabut ni, excellent lah, hypoxia patient hypoxia. So apa yang kena buat? Patient tu, you tahu patient tu, okay, patient tu sebenarnya apa yang patient perlu? What the patient need? Yang hypertensive emergency, what the patient need? GTN, okay, oxygen CPAP lah kan, positive pressure. Patient needs positive pressure. So bila insyaAllah dengan benda tu, so patient akan improve. Okay, so within 24 hours patient akan improve. Okay, tapi yang nak bagi patient improve yang dalam 24 hours tu, patient restless. So apa yang kena buat? Dia restless, dia calm. Okay, macam mana you nak calm the patient? Patient hypertensive emergency. Okay. Siapa pernah intubate? Saya pernah buat delay sequence intubation kat satu resuscitation, circulation, satu yang opposite tu delay sequence intubation. Rasa tak ada tak sini lah. Okay lah. So apa yang nak bagi patient tu senseless. Jadi tu hypertensive emergency BP 200. You boleh bagi aprazolam, you boleh bagi lidah tapi you bukan bagi induction punya dose, you bagi untuk calm, untuk patient calm. You boleh bagi fentanyl, okay, you boleh bagi lidah. Fentanyl you bukan bagi induction dose juga, you bagi low dose sahaja. Okay, kalau lidah, kalau you nak bagi berapa? Kalau adult, you boleh bagi chicken dose, you bagi 1 miligram je. 1 miligram untuk calm the patients, okay, less restless. Okay, so then you can apply the CPAP. Okay, so you boleh buat all the intubation. Okay, so lepas you bagi CPAP, patient dah come down, semua, you tengok, oh, SpO2 dia pick up. Okay, so you, lepas patient dah come down, you jangan start DTN lagi. Okay, so you start DTN after patient dah come down, you tengok BP dia still persistently high. Okay, then baru you start DTN. Sometimes BP dia high because patient tu hypoxia. Okay, so it's not really hypertensive emergency sebenarnya. Okay, so patient tu because dia hypoxia, BP dia high, tachycardia. Okay, so I have yang satu patient tu sebenarnya dia pneumonia. Okay, tapi initially orang treat as hypertensive emergency sebab BP dia 200, 200 over 100 something. Okay, heart rate dia tachycardia 130. Okay, SpO2 dia 80, 70. Okay, tak sustain. Okay, so bagi CPAP pun, okay, patient restless. Okay, so kita delaykan sequence intubation. Okay, so kita nak tahu patient ni APO ke ataupun bukan APO. Okay, so sebab you tak buat ultrasound kan. Okay, chest x-ray memanglah tak nampak. Okay, sometimes chest x-ray patient hyperinflated lung, dia tak nampak. Okay, APO, pneumonia. Okay, so you bagi, kalau patient tu APO, dia akan improve markedly dia punya SpO2. Okay, so let's say if tak improve, okay, so you bagi time dalam, let's say 1 hour. Okay, 1 hour SpO2 dia still sama. Okay, still sama ataupun worsening ke apa ke, so then you intubate. Okay, kalau dia improve, tak payah intubate. So that's what we call delay sequence intubation. So delay sequence intubation in mind, basically dalam you nak benda alat intubate dah ada dah kat situ, tapi you tak intubate lagi. So you just delay the process. So you nak tengok whether patient tu macam tu improve ataupun static ataupun reduce dia punya condition lah. So kalau improve, tak payah dah lah intubate. Okay, so that one is delay sequence intubation. Okay, kalau resuscitation sequence intubation,
kita discuss senario lepas sebelum kuis kita ada sama dulu nanti sebelum masa kita set up kuis lagi kita boleh discuss kes asal lagi nak kes lagi sebelum kuis lagi kita boleh kita sambil-sambil discuss kes
okay, alright.
kita sama. And during this meet promotion from Pfizer drug hospital for today about Unity. Untuk yang online kita buka pada Turkiye lah. Okay.
Good morning, everyone. I'm Lisa from Pfizer. So, I covers antibiotics and antifungal from Pfizer portfolio. So for UNAS, we have Unacin oral and also some antibiotics which is used in ICU like linezolid. We have oral tablets. We have ceftaroline, and we have antifungal like anidulafungin, Iraxis, and also voriconazole IV for mainly for hemato patients lah. So this is my range of coverage for the portfolio. Okay, and then so today I want to share about Unacin oral because this is the drugs that you all can prescribe in emergency department. Just you're familiar with these drugs? The oral Unacin is still original. Do you aware of that? Yes. This drugs is the oral tablet is still original in government hospital. This is the only original antibiotics for the oral one in government hospitals. It is because there is no generic in the market, in Malaysia market. There's no generic or oral Unacin. So in government hospital, it's still using the original one. Okay, so I want to share something about Unacin. So bacteriotomase is an issue. So you can see the Bacteroides groups, Staph aureus, Morazella, H. influenza, E. coli, Klebsiella, they all have the prevalence of resistance. So the other ones, can I stand here? I can point. Pointer. So you can see there is an in vitro activity of Ampicillobacter compared to ampicillin alone. In this hospital, you still using ampicillin alone?
Macam tak kena bagus.
Tak ada ni.
Amoxicillin.
Amoxicillin ada tak?
Amoxicillin.
Amoxicillin ada, ampicillin tak ada dah.
Pediatric.
Pediatric. Okay. So because ampicillin, you can see from the in vitro punya activity, actually dia sangat resistant dah. So you can see the MIC 90 is very high for ampicillin alone. But when it plus added in sulbactam, you can see the MIC 90 is very low. That means they are susceptible. Okay, it's not resistant.
MIC is the minimum inhibitory concentration.
Sorry.
MIC is the minimum inhibitory concentration.
Yes. From the then you can that one. So Unacin oral is a prodrug formulation. So you can see the serum levels of ampicillin obtained from the orally administered Unacin is higher compared to amoxicillin obtained from the orally administered amoxicillin. So they are comparing the ampicillin and amoxicillin from these two drugs, because these two drugs actually their coverage of similar, so always we will compare Unacin with Augmentin. Okay, so you can see that under AUC and the Cmax for Unacin is one scaliganda of this amoxicillin, and Cmax also dua scaliganda. Okay, so the beta-lactamase inhibitor has proven to be highly effective antibiotic strategy for tackling the beta-lactamase resistance. Okay, so prodrugs, the good thing is they will deliver and drive more antibiotic into the blood. Okay, so Unacin oral is a prodrug formulation. Then you can see we have the comparison with Unacin plus Augmentin. So inductions of beta-lactamase for Unacin is negligible. For product formulation, so yes, Unacin is a product formulation, but not for amoxicillin. Used in liver dysfunction, so no dose adjustment needed and necessary. However, use with cautions and monitor the hepatic function at the regular intervals. Okay, same as for Augmentins, those with cautions as well. Okay, so for Acinetobacter coverage, Unacin, they have a Acinetobacter coverage, and the susceptibility of injections, Unacin is stable up to 8 hours at the concentrations at up to 45 mg per ml in the sterile water or isotonic sodium chloride at 25 degrees. And we have the suspension. So after reconstitute, you can keep the suspension up to 14 days. And we have in the market with IV, IM, and oral. Oral have tablet and suspensions as well. Okay, this is the comparison with amoxicillin. And this is the you can find it here because quite small. You can see it. This is a booklet that shows the coverage of Unacin compared to Augmentin and other cephalosporin groups. So you can compare to this small booklet. The red bar will be Unacin, the ampicillin sulbactam. So it covers gram-positive, gram-negative, and also anaerobes. Alright. So we also have some studies looking into the safety and tolerability profile. We also compare to amoxiclavulanate lah. So this is ENT infection dosage in 10 days. So for Unasyn, it's a BD dosing 375. And for the amoxiclavulanate, it's 500 mg TDS. So you can see the ratio of patient with diarrhea adverse event for Unasyn is 30%, and amoxi is 70%. This is the ratio. So that means Unasyn is more the side effect is more mild compared to augmentin. Okay. Okay. And also you can see from this dosing, Unasyn punya dosing is PD saja. Augmentin, in some studies, they are using TDS. So for your practice, are you using your prescribing TDS for augmentin now?
Augmentin,
Oral.
BD.
Oral.
Antibiotik yang lain dah TDS dah banyak dah.
TDS, IV, TDS.
Yeah, some of the indications like pneumonia, they have to revise to TDS, and some of doctors still BD for the upper respiratory tract infections. So sometimes you are not sure that ini perlu bagi BD ke TDS for augmentin, but for Unasyn, you don't have to have this doubt. Tak payah worry. BD dosing for all the indications. So also will improve patient punya compliance. And jika patient TDS kan, for me also I will forget the second dose, or I don't know how to take the 3 dose dalam satu hari. So BD dosing is more it will improve compliance, and also for those fasting patients, BD dosing. Okay. And this is the indication. You also can get it from this booklet. It's well known, it's established for skin and soft tissue infection, for diabetic foot ulcer, or diabetic patients, but it has broad indications. You can see for respiratory tract infection like sinusitis, otitis media, pneumonia, UTI. We have the prophylaxis of surgical infection, that is for IV, bone and joint infections, skin and soft tissue infections, bacterial septicemia, intra-abdominal infection, and gynecological infections. Okay, so we have a lot of indication for Unasyn, not limited to skin and soft tissue sahaja. Okay. So we can share some studies that provide efficacy for upper respiratory tract infections in many studies. This for adults. Adults show the efficacies of ampicillin sulfactam or saltamicillin in adults and pediatric on upper respiratory tract infections. So you can see the infection you can see like tonsillitis, pharyngitis, acute AOM, acute otitis media, sinusitis, in ENT infections, and so on and so forth. So you can see the cure rate is the red one, and the improvement rate is the blue color. So you can see the clinical success rate actually is very high, 89 to 100%. So it's very effective on this treating upper respiratory tract infections. So Unasyn also is reliable in the treatment of the acute ENT infections. So like otitis media, tonsillitis, pharyngitis, sinusitis. So this is dosage in 5 days. You can see they are using oral. These studies in oral 750 BD or 375 BD or 750 BD. We have 2 dosing. You can up dose to 750 BD. So 1 day will be 1,100 mg. So for cefuroxime, I think this is also your frequent prescribed antibiotics. Cefuroxime is 1,000 per day. So you can see the comparison. The clinical cure rate for Unasyn is 83.6%, and for cefuroxime is 69%. Okay, so the Unasyn oral is clinically effective and well tolerated. And it is only the BD dosing to treat the adults in ENT infections. Okay. And also we also have this compared with amoxiclavulanate. Okay. the dosage in 10 days, Unacin is 375 BD, and for amoxicillin is 500 TPS. Okay, and for the data, this is the clinical cure rates. So we have similar tolerability and efficacy as amoxicillin in upper respiratory tract infections. Okay. Right, we also have many studies on these lower respiratory infections. Okay, so this is 12 studies. You can see we compile all them. We found that the clinical success rate is 84 to 100%. Okay.
This is medical student, so that's.
Dia akan ada kelas.
Alright, so this is for the lower respiratory tract infections. So I want to jump out and just shows these inpatients IDSA. The recent recommendation by this the 2019 ATS and IDSA guidelines for the treatment of the CAP in the adults in inpatient setting. So you can see over here the first one. For adults with non-severe CAP without risk factor of the risk of MRSA or Pseudomonas. So the recommendation is ampicillin plus sulbactam. But not maintained. But in the IDSA guideline, they are recommending Unacin. Okay, Unacin IV. So or others like cetrazone, cetrarolene, plus this azithromycin microlides. Okay. This is the strong recommendation and high quality of evidence. Okay. So for those adults with non-severe CAP have contraindication to both macrolides and fluoroquinolones. So they'll just take up the fluoroquinolones and the azithromycins. So the guideline is still the same. Ampicillin plus sulbactam is the drug of choice. Okay. And go up to this patient for adults with severe CAP without risk factor of MRSA or Pseudomonas. Also, the recommendation is Unacin with a strong recommendation, moderate quality of evidence. Okay, so in this IDSA guideline, they are recommending Unacin. Okay. Okay, so we go back to that. And so for we goes to the skin and soft tissue infection. So this is the Unacin actually offer coverage to the pathogens common in the skin and soft tissue infections like cellulitis, impetigo, like folliculitis, carbunculus, nephrotising, fasciitis, animal bites and human bites. All these pathogens actually is covered by Unacin. Okay. And Unacin, to just a reminder, is not active against Pseudomonas, and including those ESBL also is not covered. Okay. So we also have a good clinical success in treatment of limb-threatening foot infection in diabetic patients. So diabetic patients in the dosage in 5 days. So Unacin is 3 grams for every 6 hours, and inhibinum cilastatin 500 for every 6 hours. So we can see there is a similar clinical and microbiological success rate results. So these two drugs, so Unacin versus inhibinum cilastatin. So you don't need to use up to carbapenem groups, but you can use Unacin. Okay. And also it has the power to combat the foot infection in diabetic patients. So you can see the cure rate for soft tissue infection is 100%. It's very, very good. And for the OM is 86%. Okay, so we goes to UTI. So Unacin also has a highly suitable for the treatment of uncomplicated UTI. The dosage is 750 BD, and for another one is amoxicillin is 625 TDS. So the response rate you can see versus is similar response rate compared to amoxicillin. Okay. So in this hospital UTI, you use
Cefuroxime.
cefuroxime.
Tend to be the first choice.
The first choice.
Okay, the first choice, first second.
So it's also indicated for UTI also it's also indicated in our Malaysia PI lah. Okay. So also for endometritis, there's a suitable treatment for these infections. Dosage is 3 grams for every 6 hours, and for versus the clindamycin plus gentamicin. So we also have similar efficacies on this endometritis. Okay, so we go to dosage. So the dosage is very simple. Just now I mentioned 375 or 750 BD dosing. There's no TDS, QIV, but just BD dosing.
For all indication,
For all indications. So jika you feel that is very severe, then you up dose to 750. Jika okay saja, you use standard dose, 375 will do. So a lot of doctors say 375 actually is sufficient already. Like they seldom up dose to 750. Okay. So we also have IV and IM. So IV in dekat hospital ini dia bukan original, dia generic. So I'm not promoting for that, but you are the guna lah, that's that now to oral lah. And then we have actually suspension, tapi suspension sekarang kami tak ada stock sampai next year then. So we're not providing suspensions. Dulu we are providing the suspensions as well. Okay. Okay, so also want to do there is one guidelines I shared is management of food big food ulcer infection with Unacin. Okay, so Unacin is indicated for skin and soft tissue infection, including diabetic foot infections caused by the bacteria yeast and enterococcus. Okay, so this is the local guideline for the treatment of mild or moderate diabetic foot infection. So in 2018, CPG for the management of foot diabetic foot. So ampicillin sulbactam is a preferred treatment for the moderate infection, deep tissue infections, erythema more than 2 cm around the ulcer, and non-SIRS. Okay. So for 2019 NAG, the National Antibiotic Guidelines. So Unacin also is the preferred treatment for the mild infections, local infection involving skin and subcutaneous tissues, erythema less than 2 cm around ulcer, and there's no systemic sign of infections. And for this is the for oral. For oral, this is PO. So it's for oral. That means sulfamethylates. So for those the erythema less than 2 cm, you use oral. But for the IV one, the preferred is a preferred treatment for the moderate infections, deep tissue, erythema more than 2 cm around the ulcer, and no SIRS. So this is the guidelines for Unacin. Okay. And I want to emphasize something that is in government hospital, we always like compare because both Augmentin plus Unacin is they have a similar coverage. They are aminopenicillin groups. So in government hospital, Augmentin is generic, and the price actually is very high. Is one tablet is 3 ringgit 75 cents. Compared to Unacin, one tablet only 2 ringgit. So you can see if you prescribe one patient for Unacin, it's only 4 ringgit per day. But Augmentin, you want to prescribe one, if the dosing is TDS, it will be like 11 to 12 ringgit already per patient. Because one tablet is 3 ringgit 75 cents. So you're providing the patient an original drugs. Original drugs is always will give you consistency of efficacy. Consistency of efficacy. So and it is cost effective in government hospital as well when compared to augmenting. So hopefully that you all can, if it's indicated, then you can choose Unacid over augmenting. Yeah. So any words for the medical officers?
You think of
Specialist.
kena counter sign by specialist.
Yeah, it's the same.
So we think that you cover by augmenting, cover by Unacid juga, dan it's more cheaper.
Semua boleh.
Oh, dan more compliant lah sebab BD saja. Oh, Is there anything that you think of yang augmenting boleh bagi Unacid juga?
So itu kita nak itu tulis siapa sih? Ini ada tengok the unicorn. Yeah. This is the one. So